This explainer is based on the Australian Dizziness Clinics literature review, Cerebellar Ataxia in Children and Adults, a vestibular physician's deep review of mechanism, diagnosis, and management, available at australiandizzinessclinics.com.
Welcome back, everyone. Today, we're jumping right into part 2 of our explainer series, Pathophysiology, Cerebellar Circuitry, and the Mechanisms of Ataxia. So our main goal today is to totally demystify cerebella's circuitry and, more importantly, map it directly to the bedside clinical signs you're seeing in your practice every day. The absolute crucial anchor point to keep in mind is this. No matter what the underlying cause is, whether you're dealing with a genetic repeat expansion or an aggressive autoimmune antibody, the whole shebang funnels into one single final common pathway. It's exactly this anatomical bottleneck that makes our cerebellar examination so incredibly powerful and reliable. Let's start by taking a top-down, macroscopic view of the functional topography. Anatomically speaking, the cerebellum is divided into the anterior lobe, the posterior lobe, and then tucked right underneath the flocculonodular lobe, all neatly separated by the primary and posterolateral fissures. But for us as clinicians, it's the functional zones superimposed over this anatomy that truly matter. And that brings us to how lesion topography perfectly predicts the dominant ataxic syndrome you'll actually see in the clinic. It's like a brilliant map. The vestibulocerebellum governs our balance and eye movements. Then you've got the spinocerebellum, that's the vermis and paravermis, which primarily controls gait and truncal stability. Finally, the cerebrocerebellum, sitting out there in the lateral hemispheres, handles skilled limb movement, motor planning, and even cognition. Basically, if you know the zone, you can accurately predict the signs. Now, zooming in on the vestibulocerebellum, which, let's face it, is the absolute focal point for us in vestibular medicine, we see a really unique organization. It literally splits incoming vestibular signals into two parallel processing streams. You've got the floccular complex calibrating eye movement reflexes for dead-accurate gaze stabilization, while the nodulus and ventral uvula are busy interpreting gravity and translation for spatial orientation. This intricate parallel processing explains exactly why a single localized lesion right in this area produces such severe vertigo, impaired pursuit, and downbeat nystagmus. Okay, let's dive even deeper. We're moving from the macroscopic lobes all the way down to the microscopic engine of the cerebellum, the Purkinje-cell. These cells are incredible. They boast some of the most complex, beautiful dendritic trees in the entire human brain. They act as the pivotal inhibitory output neurons, projecting absolutely critical signals down to the deep cerebellar nuclei to drive major motor pathways. Honestly, understanding this single cell is the absolute key to mastering ataxia. Down at the histological level of the cerebellar cortex, you can clearly spot those large Purkinje cell bodies and their dense dendrites. They're situated squarely between the molecular layer on top and the granular layer below. It is a beautifully organized yet highly sensitive structure. Any dysfunction, total loss of these specific cells, or even just the disruption of their inputs is exactly where the vast majority of ataxias ultimately converge. Fanning out to look at the actual mechanisms that damage these cells, we essentially find four main routes. First up, we have toxic gain-of-function genetic disorders. For instance, the polyglutamine spinocerebellar ataxias, or SCAs, are driven by CAG repeat expansions. These produce misfolded ataxins that aggregate and literally choke the cells. Contrast that with Friedreich's ataxia, where an intronic expansion completely silences frataxin. That leads to severe mitochondrial iron accumulation, rampant oxidative stress, and subsequent degeneration. The second route is immune-mediated. This is where rogue antibodies directly attack and damage the cerebellar neurons. Paraneoplastic degeneration, for example, destroys Purkinje cells incredibly rapidly. But here's the thing. It is absolutely vital for us to recognize the non-paraneoplastic forms, like those driven by anti-GAD antibodies. Why? Because these can actually be partially reversible if you hit them with immunotherapy early enough, right before permanent cell loss happens. That's a real game changer if you catch it. Route number 3 is structural. When we consider the posterior vertebral-basilar circulation, we know that focal infarctions or hemorrhages in these arterial territories cause acute, localized ataxia, and that demands immediate recognition. In fact, an acute cerebellar stroke can present as isolated vertigo that perfectly mimics benign vestibular neuritis. That right there is what makes your careful, bedside oculomotor exam a truly life-saving tool. No pressure, right? The final mechanism to cover is sensory,
A textbook example here is CANVAS. That's cerebellar ataxia, neuropathy, and vestibular areflexia syndrome. Driven by an RFC1 genetic expansion, this causes a profound vision-dependent ataxia. Since these patients are dealing with erroneous or entirely absent afferent signals due to bilateral vestibular failure and sensory neuropathy, the moment the lights go out or they step onto uneven ground, their ataxia worsens dramatically. So, pulling this all together, regardless of whether the upstream origin is genetic, autoimmune, structural, or a loss of sensory input, they all travel down the exact same path. They converge into a single bottleneck, which is the loss of coordinated cerebellar output. It's this singular failure to modulate motor commands that ultimately results in the dysmetria, the gait instability, and the ocular motor abnormalities that define clinical ataxia.
Now, this brings us to a massive question we face in clinical practice. Why do some patients present late in life with a really insidious onset, while others hit us acutely? Well, it all comes down to cerebellar reserve. Think of this as a dynamic capacity where surviving circuitry completely and perfectly compensates for ongoing damage. The patient just remains in a compensated, completely symptom-free state until eventually a critical threshold of cell loss is crossed and that reserve just runs dry.
This reserve dynamic, it's a massive clinical pearl. It beautifully explains the insidious, delayed onset we see in slowly progressive degenerative conditions. And crucially, it highlights the absolute ticking clock we're up against when treating immune, nutritional, or metabolic ataxias. You have to intervene before that finite cerebellar reserve is permanently depleted. Otherwise, you're looking at a patient trapped in an irreversible deficit. Okay, let's do a quick wrap-up. First, topography maps the symptoms. Lesions in specific zones produce highly predictable sign clusters. Second, despite wildly diverse etiologies, everything converges on Purkinje-cell dysfunction as the final common pathway. And third, cerebellar reserve is that hidden metric dictating exactly when symptoms will actually appear. In part 3 of this explainer series, we're going to move directly to the bedside. We'll be covering the cardinal signs, the onset tempo, and exactly how to spot a cerebellar stroke.
But as you head back to the clinic today, ask yourself, how many of your idiopathic dizzy patients might be sitting right on the edge of their cerebellar reserve, just waiting for you to uncover the true cause before the damage becomes permanent? For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series. See you in part 3.